I'm your internet radiologist. Now it's your turn. Can you find the cancer? Let's find out how good a radiologist you are. This cancer finding is moderate difficulty, 40 out of 100. We have a 53-year-old female with abdominal pain presenting with a CT abdomen pelvis. As usual, we're going to go through the scan to see if you can find the cancer. Did you see it? Let's find out by going system by system. The heart and lungs are unremarkable. We're going to now continue our scan through the upper abdomen where we see the liver, gallbladder, spleen, and pancreas are all unremarkable. As we continue into the lower abdomen and pelvis, we find that the small bowel and colon are unremarkable, as well as the urinary bladder and the vaginal cuff are unremarkable as the patient is stassed post-hysterectomy. The right and left kidneys are evaluated, finding a benign cyst in the right kidney. However, in the left kidney, there is a highly suspicious solid mass. This mass has an adjacent cystic structure and is partially exophytic, measuring approximately 3 centimeters. We need to think about potential complications of this mass, the most common being invasion into the left renal vein due to tumor thrombus, or potentially invasion into the IVC, which can lead into the right atrium of the heart. We can see these vessels are well opacified, so there is no thrombus to be concerned about at this time. Now we characterize the borders of this mass to make sure they do not cross through Gerotis fascia, which would increase the staging and surgical complication for this patient's mass. We now take a look at the mass in coronal projection, where we can see the left renal mass in the interpolar region, as well as the benign right renal cyst. The patient was referred to urology, where surgery was planned. An interval left nephrectomy was performed. The patient now returns to radiology for a surveillance follow-up to evaluate for recurrence or potential metastatic disease. Evaluating the chest, abdomen, and pelvis, there is no evidence of metastatic disease. Special attention is paid to the left nephrectomy site to evaluate for any residual soft tissue nodularity to suggest recurrence, lymphadenopathy to suggest nodal metastatic disease, or post-surgical complications, including seromas. The patient received excellent surgical management. There are no postoperative concerning findings. The mass was pathologically proven to be a renal cell carcinoma. This early diagnosis and intervention saved this patient's life. Kudos to the whole medical team. Let me know if you figured it out or what I should do next.